demonstration we're going to be doing oxygen delivery. First thing we want to do is make sure our bottle's intact, there's no damage, and do a test to make sure it's the right one by getting my crew member. Is that oxygen?
Yes.
Cool. So now next thing we're going to do is grab our regulator, make sure the Bodex seal is not damaged, it's intact, so that seems to be clear. To identify this is for an O2 bottle, there will be 2 prongs and 2 holes, so we'll attach 2 prong to 2 prong, and we just slip it on like so, and tightening the windlass until finger tight. The next step we're going to do is check that we have oxygen by turning on the pillar valve. Seems like we have enough, so that's good to go. Today I'm going to use a nasal cannula. This delivers 2 to 4 litres per minute. So before I do that, I just want to check that my flow rates are working by just going through them quickly. Yep, that seems to be intact. So I'll just attach that to there and turn it on. For the purpose of this video, I'm going to turn it to 2. So we're going to have our flow rate flowing before we give it to our patient, so this will give more insufficient flow and won't give our patient a fright. So once our patient is finished with it, we're just going to take it off him and then turn the flow rate off and turn it off by turning the pillar valve. Before taking off the regulator, just go through it, flush it. So now all the air is off, and remove the regulator like so. With the bag valve mask or BVM, I just want to make sure that there's no leak first. That's just blocking the circuit. Seems like that's intact. Make sure there's no holes in the reservoir. Like pumping it up with air. Yep, that seems to be like there's no leaks. Attach your tubing. Now, with your BVM, this delivers up to 10 to 15 litres per minute. That delivers up to 100% concentration. So after we have attached our BVM to the cylinder, we're just going to apply an OPA to our patient. And for the purpose of this video, we're going to set our flow rate to 10. And using a CE grip and ventilating 6 to 8 seconds. So 1, 2, 3, 4, 5, 6. And without that time, I can get firm chest rise. And so I suspect gastroinflation, so I'm just going to get my crew member to apply conchoid pressure. And then 1, 2, 3, 4, 5, 6. So the next demonstration we're going to go through is suction. So this is the lateral suction unit. First thing we're going to do is just test it. We do that by holding the test button, turning it on to full, and just keeping the tune. Watch it not rise above 350 millimeters of mercury right to the top until it stops. Which means the test is complete. Now, just with our patient, for purposes of this video, we're just going to lie his head lateral and pull his head back a little bit. This will open up the airway more and help vomiting. So next, just going to turn it back on. Test if suction is working just by blocking the circuit and testing it on yourself. With suction, we're going to insert on the way in and suck on the way out, and no more for 10 seconds. So we're going to insert and sucking on the way out in a circular motion. So one of the contraindications if you suck for more than 10 seconds is hypoxia, which can lead to dysrhythmia. Today we're going to demonstrate the use of an oral pharyngeal airway or OPA. Indications for an OPA is if your patient scores 8 on a GCS scale or below 2 on a verbal response. The next step we need to do, or the first step we need to do, is check that there is nothing obstructing the airway, so I can see it is clear. The next step is to pick what size OPA you'd like to use. So sizing starts from 000 through to size 5. And measuring starts from the corner of the mouth along the angle of the mandible. So if we were to grab this one, I find that it is too large if I were to grab this one and measure it, it's the right size for our patient. To insert the OPA, we insert 180 degrees towards the roof of the oropharynx and twist 180 degrees while insertion, and check that the patient has accepted the OPA, which he has. Contraindications for an OPA can include vomiting if it is too large, or can damage the oropharynx or worsen the airway obstruction if it is too small. So if for some reason you can't insert an OPA into your patient, another form of airway is the Nasopharyngeal Airway, or NPA. So as said, the indications are if you can't insert an OPA, and like the OPA, but measuring starts from the corner of the nostril along the angle of the mandible. So this is just the right size for our patient. So before inserting, we need to cover the NPA with a water-based lubricant, and we insert 90 degrees to the nostril. While inserting, twist 180 degrees. If for some reason resistance is felt, keep on trying to twist 180 degrees. If resistance is still felt, take it out and try the other nostril with the same technique of twisting it 180 degrees, and until the phalange reaches the nostril. Complications for an NPA can include a basal skull fracture, bleeding, or nasal polyps. So today we're going to use the LiPo-12 to demonstrate the skill of defib management. So the first thing we want to do is check that we have paper. So the paper is located under the screen in the paper tray. So to check it, just slip it off like that. Seems like we have enough, so we're good to go. Now we just want to check that our batteries are full. So we're just going to turn our monitor around, and the batteries are located behind this pouch. So we have two batteries, and to see if they're full, just press the button on it. If you find that you need to take it out, just squeeze another button on the side and detach it like so, and reattach it with a new one with a click. So cool, that's good to go. So now we're just going to turn our monitor on, pressing the on button. And then we're just going to put it into manual mode, which we do by pressing energy select and then selecting yes. And for the purpose of this video, we're just going to take it down to 50 joules. Now we're going to do an operational test. We do that by pressing options and then user test. Since this test is going to take a while, I'll just take you through the pouches. So in this one, you'll find the ECG leads, which have already been attached to me. Also the SpO2, which measures your patient's oxygen saturation in their blood. So you attach that to their finger. Also, you'll find your ETO2, which is entitled carbon dioxide, and you attach this orange bit above the top here. At the back is your blood pressure cuff. If you find you need to take your patient's blood pressure, and you activate that by pressing the NIB button, which stands for non-invasive blood pressure. In this pouch, you'll find pads you attach to your patient when you need to shock them. Also another bag containing aspirin and razors. The razors are if your patient has excess hair on the chest, and also the 12 leads. So when the test is complete, we're looking for user test pass, which means our monitor is fully functioning and ready to work. Cool, so with that test completed, it has user test pass, so it's ready to work. So now we're just going to do a test shock. We do that by pressing charge. It will charge, and then we deliver the shock by pressing the shock button. If you find you need to disarm your charge at any point, just press the speed dial located left bottom of the monitor. Now we're going to change leads. We do that by pressing lead and selecting 213. And then to adjust the volume, I'm just going to select the top left corner and then press the speed dial and press it again to select the volume. Twist it to the left to turn it up, and twist it to the right to turn it down. To go back to the home screen, just press home, And if you need to change the size of your amplitude, just press size located beside the lead button, change it to small ones. As you can see, it's going small, or change it to very large ones if you find you need to have them large. And now we're just going to change it back into AED mode. We do that by pressing analyze.
Analyzing now.
Once it
Stand
says no
clear.
shock advised, we're going to turn our monitor off
No shock advised.
by pressing the on button. In this demonstration, we are going to be going over some vital signs, starting with Adam's radial pulse. The normal range for an adult measures from 60 to 100 beats. This is done by placing your index and middle finger distal to your patient's thumb and count how many beats you feel within 15 seconds and multiplying it by 4. Before I commence this procedure, I need to gain consent from my patient, so Adam?
Yep.
Cool. So at the same time, I'll be taking respiratory rate. To get an accurate assessment, it's best that your patient doesn't know this is happening. So can you just lay your hand out? So as I'm taking Adam's pulse, I'm just going to use a technique by placing his arm across his chest and count how many beats I feel within 15 seconds. Cool. Cool. So 15 seconds is up for his pulse. I counted 20 beats. So multiplying that by 4 will give me the answer of 80, which falls us within the normal range. Within that 15 seconds, I felt and heard 4 inhale and exhales. So multiplying that by 4 will give me the answer of 16, which falls within the normal range of 12 to 20 breaths per minute. So the second vital signs I'll be demonstrating is blood pressure. To start, we need to remove any restricting clothing from the arm, so what he's doing right now is okay. We need to place the blood pressure cuff high in his upper arm, but before we do that, of course, we need to gain consent. So Adam, is it okay if I take your blood pressure?
All good.
Cool. So is that too tight or too loose?
That's
Is that
good.
fine? Sweet. So now we need to locate his brachial pulse, and I like to use a stethoscope. So place it on the area of the artery and start inflating it till you hear it. Cool, I can hear that. Once you can't hear his brachial pulse, just give it one more squeeze. So now start releasing the stopper valve anti-clockwise until you hear the first sound to the last. Cool. So with that, for the first one I heard, which is systolic pressure, I read this at 125 and 17 for his diastolic pressure, which is the last sound I heard. So this falls within the normal range. So a patient is considered hypertensive if their systolic pressure is above 140 and their diastolic is above 90. Finally, I want to listen to the lungs to make sure that there is volume and clarity. Before I do this, of course, I need to ask for consent. So Adam, is it okay if I listen to your lungs? That
Yep.
requires 4 in the front and 4 at the back.
Yep.
Cool. So we just want to grab our stethoscope and start at the top and just place it on his chest and ask him to breathe in and then breathe out. Same with the other side. Breathe in, breathe out. Now we're coming from the bottom. Breathe in and breathe out. One more to the side. Breathe in, breathe out. Cool. Back to the back again. Sweet. So breathe in and out. And then breathe in and then out. 2 more to the bottom. Breathe in, breathe out. Last one, breathe in. Cool, breathe out. So, yep, with that final assessment, the sound was clear and good. He had good volume and there was no wheeze or crackling, which is a healthy sign. Now we're going to demonstrate the skill of hemorrhage control. So the first thing we need to do is expose the wound. Normally you expose it with trauma shears. So once you have done that and expose the wound, grab a bandage, and then we want to grab saline so the wound is clean, and just apply it on like so. Apply a bit on the wound and place it on. So now I'm going to get my offsider to help put pressure onto the wound and elevate the arm. So if you can do that, that'd be great, thanks. A bandage. So that's cool. So now we're going to wrap it around and then start twisting and going in a figure 8. This increases the pressure and hopefully it helps stop the bleeding. So make sure a lot of pressure goes on. And if you find that the bleeding hasn't stopped yet, you could apply another bandage over the top of the previous. And if you still found that it has to bleed, another option is the tourniquet. With the tourniquet, you want to apply it 10 centimeters proximal to the wound, like so, and tighten it by turning the windlass clockwise and locking it in the hold. Now it's good to document the time. If you find that it still hasn't stopped bleeding, you could apply another tourniquet proximal to the first. Also document the time on that one and check that there is no radial pulse. Since this is a painful procedure, it could also be best to give the patient pain relief. Today we're going to demonstrate the use of a cervical C-spine collar. This is Tom, he's my patient today, involved in a motor vehicle accident, he's unconscious, so I'm going to check for any C-spine tenderness. I can smell alcohol, so I'm under the impression he's had a few to drink tonight, and these fall within the nexus criteria. So if you can support us here please, as I measure him. So measuring starts from the neck to the mandible, so that's about 4. So I can see there's a no neck, so the measurement's already on a no neck. I'm just going to give it a bit of a bend by shaping it, coming under his mandible, supporting it right, and tying it like so. During this procedure, his head needs to be as still as possible. This prevents more severe damage. So with fracture management, my patient has described she has pain in her lower leg, so I'm suspecting a fracture. So now I'm going to gain consent to expose both limbs. This gives us full access to the wound. So is it okay if I expose both limbs? So this is your painful leg?
Yes, it
Correct?
is.
Okay. It's going to be a bit painful, but so now I'm going to use a mnemonic sample, which starts with signs and symptoms, which will go through the plus disc procedure. So now I'm going to ask her to rate her pain, so on a scale of 0 to 10, 0 being no pain, and 10 like being shot in the foot, how would you describe your pain?
It's an 8.
It's an 8. So this will be moderate to severe pain, which will be the use of pain relief. So with me I have methoxyl thurate. I'm just going to do a drug test, so I'm going to get my crew member to check if it's in date and it's methoxyl thurate.
Yeah, that's good to go.
Yep. So now I'm going to take my patient through the contraindications. So far she can obey my commands. Do you have any known allergies?
No,
No. Have you heard of Millikan hypothermia?
never heard of it.
No. Do you have any kidney problems?
No,
No. Have you had it in the past week?
no.
Cool. So that knocks out all the contraindications. So I'm going to hand this to you. Breathe into it and out of it like a whistle. You may feel drowsy, you may feel dizzy, a bit nauseous, and you may not have a taste. So on the same scale of 0 to 10, how would you rate your pain now?
Probably a 3 now.
A 3, so now it's appropriate to start splinting. Before I do that, I'm going to check the cardiovascular and the neurological integrity. So I feel that Her limbs are warm, which is significant blood flow. She has strong pulses in both legs, and her cap refills are normal. So now I'm going to start splinting. With splinting, I'm going to use a cardboard splint with a towel on it. The towel is there to keep it supported. So now I'm going to ask my crew member to help support the leg as I splint it under. So ready when you are.
Ready, steady, go.
Cool. So flying. Ready when you are. So we need to apply one bandage proximal to the fracture. And another one, just for this one, you might just looking at a couple of split please. One distal to the fracture. Just with this one, I'm just going to do a trigger behind here, just to give it, just to anchor it. So now we're just going to go through the cardiovascular and the neurological integrities again. So her legs seem still to be warm. She still has her strong pulse. And her cap refills are normal. So how's this one? Is it comfortable?
Yeah.
Cool.
All units code purple in Monaco on Great South Road. All units code purple. AUT1 responding.
So we've just responded to a cardiac arrest. First thing I want to do is use the new one doctor's ABCs. So I've assessed to see if we're any danger, so I can't see, smell or hear anything that can put us into harm. So now I'll check for a response. As I'm doing that, sorry. Hello sir, can you hear me? Hello sir, it's the ambulance. So I find that there's no response to verbal and pain, so now I'll check his airway. I can see nothing obstructing the airway, so now I'll check his breathing. I'm checking for chest rise and fall, and I'll do this for 10 seconds. So I find this to be an absence. Can you start CPR please? I'll attach this, so we're looking around you. And pull it back up. AUT1 calls.
Go ahead,
Push
AUT1.
analyze.
Confirming R49 patient, requesting R50 backup.
Copy.
So now I'm just going to insert an OPA.
Connect electrode.
And I'm going to turn our bag valve mask on and put the flow rate to 15. So from here we have flow rate.
Push analyze. Analyzing now. Stop motion detected.
Oh, stand clear.
Stop motion. Analyzing now. Stand clear. No shock advised.
Cool. Start back to
Start
CPR.
CPR.
And tell me when you're at 25. So when we're doing CPR, we want to have 1/3 chest. So chest rise, and we want to maintain 100 beats per minute, and with full recoil. So at the end of this 1 minute, we're going to swap. We'll take over the BVM, and I'll start CPR.
25, 26, 27, 28, 29, 30.
Chest rise, chest rise. So the normal ratio for CPR is 30 to 2, no matter who.
28, 29, 30.
Ventilating and chest rise.
30.
Chest rise. Chest rise. With the BVM, we're using the technique of the CE grip. Cool.
Push,
Analyzing
analyze.
clear.
Push, analyze. Analyzing now.
So cool.
Stands clear.
I'll stop the CPR.
No shock advised. Start CPR.
So, $27, $28, $29, $30. So does anyone know this patient?
No.
Does anyone see what happened?
No.
So that takes out all the contraindications. We also have suction with us, just in case our patient starts vomiting.